everybody. Happy New Year and welcome to our January edition of our Care Partner Meetup. I'm Polly Dawkins, Executive Director of the Davis Phinney Foundation. So without further ado, let me introduce you to Connie Carpenter-Phinney. Hi, Connie.
Hi, Polly. Thank you so much for introducing us and getting us going here. And thanks to everyone for showing up. My goodness, we have almost 100 people showing up this second day of the new year. And we weren't sure if people would remember there was actually Tuesday, because with a holiday, it gets confusing. So I'm happy everyone's here. I just want to welcome everybody to this space for this hour. It always goes way too quickly, but here we are. And I think, because some of you may be new, we kind of discovered that last time when we took a poll that we had a lot of first timers, and I think that we get that. So instead of me introducing our panelists, I'm going to let them introduce ourselves, but I'll start also to say that I am one of the co-founders of the Davis Phinney Foundation. I'm married to the guy with his name on the foundation, and we've been living with Parkinson's since the year 2000. It's a long time. So I'm happy to be here to share my expertise and, help you through this journey. And I'm just thrilled to be month after month joined by two excellent co-panelists. So Pat, you want to introduce yourself?
Happy New Year. Good afternoon. I'm Pat Donahue, and I'm coming from Las Vegas. I live in Las Vegas, Nevada. And I'm not with her right now, but Sydney is my wife, who has Parkinson's. She was diagnosed in 2010. We first noticed her symptoms in 2006. Good to be here.
And he snuck off from his lunch break at school to be with us. So appreciate you, Pat. Yeah. Gail, you're next.
Hi, my name is Gail Gittin, and I am a seasoned care partner. My husband, Gene, had Parkinson's for more years that we can really document. He passed away 3 years ago, and I love all you care partners, so I'm sticking with it. I'm sticking with you. So I'm available, and my hat's off to all of you. I know what it's like.
Oh, thanks for being here, Gail. And as a reminder, Gail and Pat are both ambassadors with the Davis Phinney Foundation, and you can reach them through our ambassador portal. But our special guest today is Jessica Barr. And Jessica, I'm going to let you introduce yourself, and then I might add a little bit to that. So
thank you so much. Thank you guys for having me. I'm Jessica Barr. I'm a physician assistant with the Movement Disorders Group at University of Colorado Hospital. I work at Anschutz as well as a Boulder clinic, satellite clinic, and I mainly treat Parkinson's disease. So Parkinson's is my specialty. My mother has Parkinson's disease as well. She was diagnosed in 2015, started having symptoms a few years before then. So I kind of have it on both sides. I treat Parkinson's and also live with someone who I care about deeply who has Parkinson's as well. So I'm happy to be here. Thank you guys for having me.
Thank you, Jessica. And just full disclosure, Jessica is the PA in the practice that that we frequent, that we use. So that's how we met her, and we were able to get her here because it's her day off. So we really appreciate you being here. It's such a great. It's just great to have you. And there's so often that we're asked more medical questions. And I want to remind everyone that's listening that we are here for you, the care partners. We're not really here to dispense medical information. However, there are times when I think it really helps for us to discuss various courses of not only medications, but, your lifestyle choices and those kind of things that do come up. So we do end up kind of prescribing, but we feel more confident doing that when we have an expert in the house. So I'm so happy you're here, Jessica, to share some of your experience and your story. And it's so much more, it's compounded because of your mom, and because of the intimate nature of your experience with Parkinson's. And I think that's that's important, and I think it'll be beneficial today. So we want people in the audience thinking about questions they might have for Jessica that are specific to their needs, their needs when they visit their doctors, what kind of questions maybe they don't get answered when they're in the doctor's office that they wish they could understand better, those kind of things. And also just if you're taking care of yourself, that's really what we're here for. And so in line with that, just to start out, I want everyone, and I like to start this way, it's a new year. It's a new Care Partner Meetup, and I think we all need to just take a big, deep breath together and really be here, okay? So let's breathe in, this new year, fill our lungs, just let it all in, and then blow it all out. Okay, we're really here. Let's do it again. A nice, big, deep breath. And out. And kind of take in the love and support of this group, 100 of us, taking an hour of our day. So one more breath in for this support and this love. And let's let out the anxiety we might be holding in as we go into this new year. Thank you. Always feels good to me. Being a former elite athlete, that's one of the techniques that I probably learned standing on too many starting lines before competitions, but have found that it works in so many different places, whether it's in the doctor's office or with small children or with my recalcitrant husband with Parkinson's. Because one thing we know is our people with Parkinson's can be very stubborn. And so can we. So let's start out with some questions. And I wonder too, Pat and Gail, do you have a quick question or thought as we launch into this? And please feel free to ask questions in the chat and we'll get to you. But Gail, Pat?
No, Jessica's also part of our care team. And like most of us, when we see a member of our care team, we just relax a little bit and just want to hear everything they have to say. So
yeah, I have lots of questions, but probably need to go off script here and do it later. But we just met with a wonderful PA. I was interested in hear that you were a PA, and that we met with a gal that's a PA that's also trained in programming. Is programming with DBS? Do you have that experience with that as well, or?
Yes. So I definitely do DBS. We're University of Colorado Hospital is a big DBS center. So we do a lot of programming. So I'm definitely part of the DBS team and do initial programming. So yes, someone who put in the chat, DBS is deep brain stimulation, which is one of the advanced treatments for Parkinson's.
I just found it real interesting that a PA would be that well-rounded and everything. So that was educational for me, and I'm glad that you're here to add to that.
Yeah, and I just saw someone in the chat says, what is a PA? It's a physician assistant. So we call them APPs or advanced practice practitioners. And that encompasses physician assistants as well as nurse practitioners. And we pretty much do the same thing. So we have our physician assistant license. We're able to prescribe medication. We work with diagnosis. We manage. The main thing I manage is Parkinson's disease. So I manage medications. I see people for their normal routine follow-ups. We do DBS workups. We do DBS programming. So we pretty much do most of the same things that your movement disorders physician would do as well. We work on a team with our physicians. So we have a group of physicians at UC Health, and I work with every single one of them. So we work as a big team pretty much. And oftentimes patients will see, they'll alternate where they'll see me maybe once or twice, and then they'll see the physician for their next visit. So we're really part of the whole care team.
What
Right.
made
So-
you told me that you told us that you actually had already decided to specialize in neurology and particularly in movement disorder. But I'm wondering, before your mom was diagnosed, and what was the primary motivation?
I just always loved movement. I loved how learning how the body moved and in different ways. And I grew up dancing. And so that just learning how the body could position in different ways, I just thought it was always fascinating. And so kind of learning the different ways the body moves abnormally and learning how to help improve that. I always thought it was very, very interesting. So,
Yeah, that's amazing. And, interestingly, and then I can see we have a lot of questions building up, but interestingly for Davis, not the first movement disorder doc we saw, but the first one that we really settled on had also had a dance background.
oh, interesting.
That's Helen Bronte Stewart at Stanford University, and her deep motivation to help Davis move better and not satisfy herself or him, let him be satisfied with anything but the best care, the best level of movement was so important to us. And so I find that fascinating that's really a shared link between you two and something that I can really resonate with, because I think that everybody experiences Parkinson's differently and the loss is experienced differently, right? Whether depending on your symptomology. And so, for Davis, of course, movement was really key. So I appreciate that. I'm happy to know that. Wouldn't have known that.
That's
Polly,
very
jump in. Yeah. Jump in, Polly, with some.
All right. First
Yeah.
question comes from Stephanie. Is it known that people with Parkinson's have personality changes with extra levodopa?
Oh.
Well, I think a lot of the dopaminergic medications can affect your personality a little bit differently. There are certain medications that can do it more so than others. So the dopamine agonists tend to be the ones that we kind of think about primarily with kind of obsessive compulsive behaviors. Or more impulsive type behaviors, so shopping, gambling, or hypersexuality. Whereas if you were not on those medications, you wouldn't have much interest at all. You'd have very good self-control. But if you were on dopamine agonist and you are sensitive to the side effects, we can see some people who become impulsive, do things without thinking about it, maybe shopping excessively. I think I put one patient on it and a week late, we always try to warn people of these side effects. And a week later they called and said, I bought 100 golf shirts last weekend. Is that what you're talking about? I was like, yes, that is the impulsive shopping that we're talking about. Whereas if they weren't on those medications, they would have never done that.
Oh, can I just stop 1 second? Because I want to say, even though we're laughing about that, we have had, a lot of people weigh in on this, and there can be some really serious consequences to that. So one of the things we talked about last time, I think it was last time, was that when you notice those behaviors, they may seem a little amusing or a little weird, but you need to call your PA or your MD or your nurse practitioner. You need to call that office right away and let them know, right? Because that's not a desirable outcome.
No, it's not a desirable outcome. And it actually can really get you into a lot of big trouble. We've had patients who've gambled away their entire retirement. And obviously nobody wants to do that. But it's a side effect of the medication. And the interesting thing too is the person with Parkinson's may not have any insight at all that they're doing this. And so it's actually a really important thing for the caregiver to know that these are possible side effects of these medications. Because it's oftentimes the care partner who notices it first before the person with Parkinson's. And the care partner can bring it up to the provider who did the prescription. And the best treatment is actually getting them off of that medication. And oftentimes when you get off of that medication, that resolves. We can see it with really, really high doses of levodopa, but it's more often with those dopamine agonists.
Thanks, Jessica.
Yeah, great answer.
Molly asks that her husband has been coughing for a few years, but lately it's gotten worse. Is this a symptom of Parkinson's? And then there's another part to the question, which is probably for the other panelists. He won't let me come to his doctor's appointment, so I'm not sure what to do. So maybe, Jessica, if you could answer about the coughing and maybe also about the second part, but maybe Pat and Connie and Gail have other thoughts on the doctor's appointments attendance.
Coughing isn't typically a Parkinson's symptom per se, but we do see postnasal drip that can kind of trigger coughing. So rhinorrhea is the fancy name for nasal drainage. So we can see a lot of nasal drainage with Parkinson's. And with that nasal drainage, you can get some postnasal drip that can kind of tickle the back of the throat that can cause coughing. So that is something that we can see in addition to that. So sometimes treating the postnasal drip can be helpful. The other thing with coughing, so it is good to talk to the provider, because other times with coughing, it could be a sign of reflux. So if you're getting food that's kind of coming up and tickling the back of the throat, that can trigger like a chronic cough. And that may not have anything to do with your Parkinson's and can be treated with your primary care provider. And then the other thing is, if it's coughing with regards to eating and drinking, you always want to make sure they're swallowing okay and they're not choking. So seeing a speech therapist can sometimes be helpful for that. So it could be a couple of different things, and trying to tease out which one it is can be helpful. And that's where talking with your provider, who they can kind of ask some follow-up questions to explore, that might be helpful.
So that's her problem, though. I think it's her, right?
That's the problem.
Doesn't get to go to the doctor appointment.
Exactly. So that's where you guys come in. What do you guys recommend?
Well, I always say like 100% you have to go to those appointments, and especially when there's nagging questions that are that serious, because I would guess maybe it is related. Let's say it is related to swallowing. There's something you can do about it. There's physical therapy for that, right? And there's tests that they can do to measure how it's going. And if you wait too long, it's just going to be that much harder to regain that capacity to chew and swallow without choking. And, so it's so important. And that's a huge problem. But, I know in your practice, Jessica, I was struggling with that question. At UC Health, they have such a great portal for communicating with the doctors. And if you don't have that in the practice that you're seeing, I really want to encourage you to find one that does have that, because you need to have that connection, especially if your person isn't letting you go. However, they do need to give you permission to communicate with the doctor on their behalf. And that's another tricky thing we've discussed often on here, is signing those release forms so that you can talk to your provider on behalf of your person with Parkinson's. Pat or Gail, do you have something to add to that?
I was just going to say, even if they don't have that portal, you can find the email for the doctor and, send him some of your concerns that he can address at the interview. I don't know how you can sneak in someone signing off on giving you permission to converse with the doctor, but if you could just get a message to the doctor that my husband won't let me come, and these are some of my issues. That might be one way to approach it. But I mean, it's just not fair to the caregiver.
And Jessica, what would you do in that case if the person said, "I don't want you to talk to my wife or my husband"? You have to honor that. Or
you do. So if the person has capacity to make their own decisions, if the person says they don't want you talking to anybody else, legally we cannot talk to anybody else. So it is a little bit tricky. You definitely have to honor that patient provider confidentiality. So it is a little bit tricky.
Do you have people that bring in on their phone to record the conversation, which is something I encourage as well? But it might not be as normal if the person's coming in without their care partner, but I was thinking if that could be, you know, that's sort of the bridge. And Sam, who's monitoring the chat for us too, whose father has Parkinson's, just mentioned that in a message, because you know, you can get an app on your phone that records really seamlessly and would be very helpful. Or you could put your care partner on the phone with you in the meeting room.
Yeah. We have a lot of people who do that. Yeah.
Okay.
I have an excellent free app, and I use it when I am going to a meeting and I have to take minutes. It's called Voice Memo, VoiceMemo. It's fantastic. It's so easy to use. Just download the app. It's a free app, and the recording is just crystal clear. But Jessica, if I sent you a note, if I sent the doctor a note saying, please address such as these things, the doctor would read it and address those issues, right? I could tell you what's bothering me as a care partner.
Yes, yes. So even if the person with Parkinson's didn't want me to share information, if you sent me a message and said, these are things I'm concerned about, I could still bring that up during the visit. But I couldn't share what the response is to the provider.
But you can also encourage your patient to include.
Yes. Yeah, that's actually a very, very good point. You could reach out and say, encourage them to let me come, encourage them to let me join. That's actually a really, really good point.
Yeah, because sometimes they just need to know that it's going to be helpful, right? That the outcome is beneficial for everyone. And, you know, in a relationship, especially with couples, in a family, the Parkinson's is not just the person that has the disease, right? Parkinson's is not just affecting them, it's affecting the whole family, and particularly the spouse. And so, you know, it's only fair to bring us in. I understand that it may feel uncomfortable and it maybe crosses some privacy lines for some people. They feel that, but the kind of care you can receive by broadening your care team and really including people is only going to help you. You know.
Yeah.
Any of us with some anxiety at a meeting will miss half of what's being said to us because we'll keep on thinking about the answer to the question before. Maybe you encourage your spouse or partner to take a recording that person can use later on, to listen to it again, make sure he gets everything right and doesn't blow off some of the things that were said because he was hooked on what was said before.
Good point.
Good point. Yeah. A clarifying question, Jessica. Somebody asked, what is a dopamine agonist? And we'll throw a link up as well, but can you briefly describe what that is when you referred to it?
Yeah, so a dopamine agonist is one of the dopaminergic medications that we use to treat Parkinson's. So kind of big overview, Parkinson's, as we know, is a lack of dopamine. And so all the medications work on the dopamine system. So levodopa is the main one that we all know, also known as Sinemet. Levodopa replaces your dopamine that is lost. A dopamine agonist is a different class of medication that kind of mimics dopamine and tricks your body into thinking you're getting dopamine. And the different kinds of dopamine agonists are like the new Pro patch, Mirapex or Pramipexole, Ropinirole or Requip are the different forms of the dopamine agonists that we use to treat Parkinson's symptoms.
Okay.
Yeah.
Now, another couple of questions people have. Susan says that her person with Parkinson's, when they have a viral infection like COVID, for example, has an increase in motor and cognitive symptoms. And is that something that you've seen?
Yes, that is classic Parkinson's, actually, unfortunately. So one of the things with Parkinson's, as we know, is it's a kind of a slow, gradual progression over time. The only time we see these big kind of flare-ups is when there's a stressor on the body. And one of the stressors on the body is an infection. So classic infections like a urinary tract infection or COVID or a pneumonia. Anytime your body has an infection or a stressor on it, we see a flare up of the Parkinson symptoms. And it can be the motor and the non-motor symptoms that flare up and get worse. Oftentimes, as the infection goes away or gets treated, those symptoms will go back to their baseline. So it's not a new normal if it's a small infection. It's just a flare of the symptoms and then they go back to their baseline. I think another thing that's actually really important to know about that is, say your loved one with Parkinson's isn't showing any signs of infection, but all of a sudden they have an acute worsening of their symptoms, where it feels like a light switch got turned off. Like, what just happened? The first thing we do is actually look for infection, because infection is the #1 cause of an acute worsening of symptoms.
Thank you for that.
Yeah.
Becky says that her husband with Parkinson's has toes that bend upwards and it hurts. His neurologist doesn't know what to do. Any help would be helpful.
It is always tricky without actually seeing it, of course, to know exactly what's going on. But a common thing we see with Parkinson's is dystonia. And a common thing is called the striatal toe, which is where the big toe will kind of go up. Oh, we got a video. Yeah, so that's that striatal toe, that first toe that's going upward, and the other toes can kind of curl down. That's kind of a dystonic. The video's a little blurry.
I don't know why, but
We could see it a little bit there. I mean, you just think about it as it's just your big toe can sit up like this. Davis has this as well.
Yes. So the big toe goes up and oftentimes the other toes kind of curl down. It's a common dystonic posturing that we see with Parkinson's. Dystonia is just an abnormal contraction of muscles that cause an abnormal posturing. And it can be a mobile posturing or kind of a fixed posturing. Oftentimes medications can be helpful, but another common treatment that we do is Botox injections, where you actually inject the muscles of the foot to kind of relax the toes a little bit.
Some questions, Jessica, back to stressors that cause flare-ups. Can traveling from time zone to time zone be one of those things?
Yes. Really any kind of stressor. So travel can definitely be a big stressor, especially when you're not sleeping in your same bed, you're in a new place. It can definitely flare up those symptoms a little bit more, especially when you have big gaps in your time zone. So if you're going to Europe or something, and you're really changing your medications, it can take a couple of days to kind of get onto a new schedule. So traveling can definitely be a stressor. Things like moving can be a big stressor where we can see a big flare up. Any kind of family stress, we can see kind of a flare up in the symptoms as well. So any kind of I guess the best treatment is always trying to reduce stress as much as possible, and keeping things on an even routine can be the most helpul. Although it's easier said than done.
Yeah, I did see that. Yeah, exactly. I did see someone ask, could just a simple argument in the home cause this problem? And this is one of the things that makes us care partners feel so guilty. And also like with our hands tied sometime, where we can't express, our needs in the family sometimes, because it ratchets up the person's Parkinson's, and then we have to, take it down a notch, but we don't get a resolution. And, and this is it's kind of a tight circle that you end up, forming. It just gets smaller and smaller. And we always say, big discussions with our person with Parkinson's need to happen when they're well rested, you know, and hydrated, and sitting down and calm, and then try to monitor your tone of voice, and it's hard, and it requires quite a bit from us to try to communicate. And when we do blow up because we're upset about something, and this happens in the course of every marriage, every relationship, it just ends up to be so difficult. And I don't think there's a real workaround other than to say you just have to change your tactics a little bit. I'd be curious if Pat and Gail have suggestions as well, or Jessica, you've seen this, just to add a little bit, because it always helps to have some tactics. It's a tactical situation.
Yeah.
When we moved, I had a friend take Gene away for the day. So he was not even present when the movers came, when the things were delivered to the house. If he could have gone away for 3 days, it would have been best for both of us. So that was a big save because he was so anxious about it.
Mhm.
And then that's basically what you have to do, is try to get them away from the situation before the problem arises. And I always kept on thinking, whenever I got really frustrated, I would remember his words, "Gail, I'm not doing this on purpose." So that would just make me, that would take all the air out of my argument. There was nothing left. After that, there was nothing left for me to get anxious about.
Well, I try to put that in front of the cart, and know that I know that she's not doing this on purpose. And a lot of times, sometimes I'll be frustrated, or you could be frustrated about something that has nothing to do with your partner.
Mm-hmm.
And yet it still affects the tension in the air or what have you. And there's such, we just traveled over the holidays. We went to a doctor's appointment at Northwestern in Chicago. And we just know that when we're going to plan to travel and then have some time to relax. And then when we get home, know that those symptoms are going to be they're going to come up and be exacerbated, a lot more prevalent. And then to make everything casual and calm to get back into normal swing. And we've been home we've been home a week now, and we're getting back into that normal swing now.
Yeah, I think those are really good points, you guys. Thank you so much. And especially, Gail, it doesn't always help to know that they're not doing it on purpose. I get that. It's still like, come on.
I know, but there are those times that, I just, it just destroyed me when he said that. I just felt sick
Mhm.
because
I caught myself this morning doing that.
Yeah. Yeah. All right, Polly, what else?
Yeah. Nancy said that her person with Parkinson's has started having episodes where he gets very irritated and angry. Is that typical of Parkinson's?
We can see that. We definitely can see that. With the lack of dopamine, we can certainly see increased depression, increased anxiety. It's extremely common with Parkinson's to have anxiety and depression. And oftentimes that can come out as irritability. So kind of doing some exploration to see where the irritability is coming from. And sometimes treating that can be actually very beneficial. It also, I don't know your person, but also oftentimes too, as Parkinson's progresses, when we start getting dementia, we can see sundowning, where people can get irritable and angry in the evening time, or when they're really, really tired. And there are medications that can be helpful to treat that. So talking with their provider and looking at different options of treatments for that could actually be very beneficial for both of you. Yeah.
Right.
And can I just, well, yeah, I had a thought on that too, because I think that the medications themselves can make you very moody,
Sure.
because it's on, off, and even the anticipation of the off, right? Like, oh, I'm feeling good right now. How long will this last? you know? I
Yes.
mean, it's such a cycle, and it can be hard, and it's really on the person with Parkinson's and their practitioners to find a schedule that works and that the person stays on the schedule. And it's easy to lose that too. But I think moodiness can be, associated just with that whole med cycle. And it just might take learning some other techniques, encouraging the deep breathing and meditation and other modalities, to help just manage that. Know that it's coming. Know that, also the good feelings are coming too. It's just, rolling with it. And that's a really hard thing about Parkinson's, it's just not status quo. There is no status quo.
And everybody with Parkinson's is different. And things we hear about and we read about and everything doesn't always mean that's what's going to happen to you, but sometimes it does, and never know. What I hate right now is that when Sydney is so frustrated with her dyskinesia, and that's what we're struggling with, she'll start hitting herself, and she'll start crying and starts yelling and screaming at herself and at her legs and everything. And my technique for that is to get her on the floor and just, rub her leg and what have you, and just help to calm her down and not do that to herself. But these things are frustrating. And so to be in their mind, it's hard to take what I know and how I would do myself, how they are handling it, because they're on medications, they've got a degenerative disease that's taking it away from them, and things like that. But it's it's being caring and putting yourself out for them. And sometimes it's hard, because sometimes there's people out here that are fed up and just don't know what to do next. And we get that. But it's always never giving up. That's the attitude that I have, that a lot of us have, is that, Babe Ruth said it best: don't give up, never give up. And so
you're so fearless in this regard. And it is,
I'm not perfect, but I'm fearless. Okay.
you are fearless. No, none of us are perfect.
Yeah.
Doctors aren't perfect.
Yeah, true.
I mean, we're all in, it's like a big guessing game half the time. But I think that your fearlessness serves you. I think another thing that really serves us in this space as care partners is forgiveness.
Mhm.
And so forgive your own behaviors when you get frustrated. Forgive yourself for that. That's number one, please. And if you have to stop and take a break, you need to do that. It's just take a deep breath, reset. We use that word a lot around here. We got to reset. Don't hold past behaviors against yourself or your person with Parkinson's. You have to, this is an active process. Forgiveness is a daily process when you're living with a person with Parkinson's, and you need to talk about it. And sometimes it's hard to talk about, and you can both share your dislike of the disease. Nobody likes Parkinson's, but as Jessica knows, she chose this field because she can help people get better. And so I think that's what's important too.
Yeah.
And that's what keeps you going, Pat. You can help Sid get better. And I think
yeah, I'd love to see her get better. I'd love to see her taking ownership of what she has. And she also is doing a lot of the research and bringing it to me to learn and to grow from. We're learning so much right now. I mean, having just been to Cedars-Sinai and to Northwestern, and as well as our own MDS doc here in town, there's so much to be had. There's so much coming out. There's a new book on exercise that just came out a couple of weeks ago. That's always just exciting stuff to read about.
Jessica, so many of our care partners get super frustrated because they feel that their person with Parkinson's is unmotivated, won't get up from a chair, won't participate in their care. But I tell them there are a lot of factors at work there. A lot of it might be anxiety. Maybe you can address that, because that's across the board one of the most frustrating things for our people.
Yeah. I think something to touch on, what you're probably alluding to, is apathy. Some of that decreased motivation to do things. And apathy is huge with Parkinson's. It's extremely common. A lot of our patients with Parkinson's or people with Parkinson's have that apathy, decreased motivation to do things. And it is part of the disease, unfortunately. So most of the time, the people want to do better. Nobody wants to feel about poorly. The people with Parkinson's want to be doing better, but they just have this internal decreased motivation so that they can't get up and do things. And I think one of the big things is not blaming the person with Parkinson's, and being patient with the person. And sometimes lowering your expectations of them can actually be a little bit helpful. Knowing you want to encourage them to do things, and sometimes treating the apathy. Well, one of the biggest things of treating apathy is external motivation. So that internal motivation is really down with Parkinson's, but having external motivation to get up and do things can be very helpful. So one of the things that we say to help treat that apathy is having things scheduled, and coming up with routines. So if exercise is something that we all know is extremely helpful for people with Parkinson's, so getting into an exercise class that's on the same day, same time, every single week, so that the person doesn't have to be motivated to go exercise. They just know Mondays at 11, I'm going to Pedaling for Parkinson's, and I'm just going to do it. So having a group exercise thing can be really helpful because it's that external motivation of the group. It's scheduled for you. You don't have to set anything up. You just show up and go. That's kind of an external motivator for people with Parkinson's.
I attended a lot of things with Jean.
Yes. So going and doing a lot of the exercise classes allow the care partner to go with you. And that's a huge motivator, the going together and doing things, exercising together, eating well together, changing your whole lifestyle together versus putting it all on the person with the Parkinson's.
And can I also add that this is another reason to know other people with Parkinson's, because sometimes I know this happened with my person, that somebody else was the one that actually would pick them up and take them to the cycling class to begin with. And that was a big boon. They developed camaraderie over that. They knew what time it was going to be, like twice a week. I didn't have to get involved. It was really a relief. And so, whether or not you join some sort of support group to meet people in your community or reach out, find things that, for some people, they don't want to get on an exercise bike, but there's, Tai Chi, or there's boxing, or, there are other modalities that will help you and your person with Parkinson's to, hopefully get off the couch. But in the end of the day, there's a point at which we had Dr. Aaron Hogue on here, and he just said, at some point you're just going to have to say, I can't help you, and just give yourself permission to understand that that's where you are in your journey with this person. And it's sad, it's hard, but it's also, sometimes it's just beyond your grasp. Polly, we only have 15 minutes.
I know. I'm going to try to focus on the ones that are a little bit more medically related.
Okay, good. Let's go.
Because we've got so many on grief and others. But one question is, can you talk about the effects of anesthesia on a person with Parkinson's?
It's different for everybody, of course. But anesthesia, I guess the biggest concern that everyone has is cognitive side effects. And of course, it's dose dependent, it's length dependent. So if you have a big surgery coming up, if it's a really quick 20-minute surgery versus a 5-hour back surgery, that's going to be a different response. So the higher the dose, the longer you're under anesthesia, the bigger the risk. And so trying to minimize the amount of anesthesia is is better. So there is a risk of cognitive impairment post anesthesia or post surgery. Oftentimes it might be short-lived, where you may be a little bit more confused, increased risk of hallucinations right after surgery. It might take a little bit longer to recover cognitively after surgery. Oftentimes people will go back to their baseline, especially if it's a shorter surgery. It also depends on where you are in your disease with Parkinson's. If you're early on and your cognition is still very, very good, the cognitive side effects of anesthesia are much less. If you have cognitive impairment or early dementia or dementia, and you get surgery, the effects of anesthesia are going to be much greater. So it kind of depends on where you are in your disease. And I'll just put I'll just throw this out there as well for anybody who's thinking of surgery. The Parkinson's Association of the Rockies, they have an Aware and Care kit. So if you go onto the Parkinson's Association of the Parkinson's Foundation, Parkinson's Foundation website, and you go to the Aware and Care kit, they have a whole surgery section with Parkinson's. They have a kit they will mail to you for free. They also have everything on their website if you just want to print it out. And it kind of goes through all the concerns with surgery and Parkinson's. The number one most important thing is there's a form that has a list of medications that are safe to take with Parkinson's and a list of medications that are not safe but are commonly given in a hospital after surgery. And you need to print that out and give it to your surgeon. It's really, really important that they have that list. If they have that list and they make sure they give you the correct meds after surgery versus the meds that deplete dopamine, it can actually really improve your outcomes of surgery. So that would be something I would really check out if your person with Parkinson's is having surgery soon.
Thank you for that. And the Davis Phinney Foundation also has a list of all of those medications that are contraindicated that we can link you to as well. Thanks for that. Somebody asked the question, if I can find it again, about if your person is experiencing orthostatic hypotension or orthostatic blood pressure changes, is it best to work with your primary care physician, your movement disorder neurologist, or have a cardiologist in the mix? Can you talk with us about that?
And define it first.
Yes.
So orthostatic hypotension is a drop in blood pressure with a change in position. So oftentimes it's measured by checking a blood pressure and heart rate while lying down after 5 minutes, and you stand for 3 minutes and we check your blood pressure and heart rate again. And if the top number on the blood pressure drops 20 points or more, it's considered orthostatic hypotension. And it's part of the autonomic dysfunction with Parkinson's. It's very, very common with Parkinson's disease. We see it very often. And it's important because it can lead to lightheadedness, dizziness. It can cause passing out or falls. It can be a common cause of falls with Parkinson's. So treatment of it is important. It can be very difficult to treat, as I'm sure some of you guys know if your person has that. But I would say most of the time, it's the movement disorder specialist who manages it. We manage it all the time. If the person has a complicated cardiac history as well, a cardiologist will be involved. So if there's no cardiac history and it's just the orthostatic hypotension, the movement disorder specialist should manage it. If there is any cardiac history, you should have a cardiologist involved as well.
Thank you.
And this is really important to understand this, because I've seen people just topple right over at the, standing up from the dinner table and from this. And, sometimes it's hydration, sometimes it's other things, but quite often, as you said, it's the autonomic nervous system acting up, and that's autonomic. Just think automatic. It's things we normally rely on, that normally our body is able to equilibrate when we go from sitting to standing, and in some cases that's lost. Polly, what else are we missing?
Well, many
You're
comment.
awesome. People want you to come back.
Yeah,
every
yeah, come
month.
back. Many people don't, many people where they live don't have access to teams that include people like you, Jessica. So people are grateful. We all are grateful that you
Thank you.
are here. Yeah.
Yeah.
This isn't medically related, but I know many of you have experienced this. Is it time, or how do you know it's time to move to a single floor home without stairs? And how do you make that decision?
Day one. Day one.
Now?
Why do you say now, Connie? What's your
Well,
experience?
for me, I mean, as soon as our children were pretty much gone from the house, we downsized into a 1-floor condo with an elevator. And, we've just been so fortunate because we really did need it right away. I mean, and we don't need it all the time, but it's also, it's very hard for those of us who lived in a house for 20, 30 more years to downsize. But once you do, the load on you is greatly reduced. And so I think it's important to do that. And also because you just don't know. And it minimally make sure there's a bedroom on the main floor that's easily accessible. But the more you do stairs, the more you're going in and out of a shower with a lip, or worse, having to step into a bathtub, the more risk you're putting not only yourself as you age, but your person with Parkinson's whose balance is unsteady. So, the thing we did when we downsized was to change the shower to make it a lipless shower, number one, and then put in all the, grab bars, and, do it before you need it. And it takes time. So my advice, I don't know, Jessica, I don't think you even need to weigh in on that, because I think it's just like people are going to do it when they can, and I know, Gail, you've done it. Pat, you've had to manage.
We bought our home. We moved into our home 23 years ago, and the master bedroom's downstairs. And I remember distinctly thinking, well, you never know, someday we might need to be downstairs.
Yeah.
And
At least that's the minimum. Yeah. Yeah.
Yeah.
Another question, Jessica. Ron asks, do you have an exercise regime that you recommend?
Anything that you'll continue to do. The best exercise is the exercise that you'll continue with and that's sustainable. The most important thing for everybody, people with and without Parkinson's, is to be moving and continuing to move. The best research is on high intensity exercise. So exercise that gets your heart rate up. That's the kind of the best data behind slowing the progression of Parkinson's is high intensity exercise. So you definitely want to get some exercise that gets your heart rate up and gets you breathing heavily. I think it's 30 minutes, at least 3 times a day of 80% of your max heart rate is kind of the minimum. But of course, the more you do, the better. It depends on what you're focusing on. Of course, Tai Chi is really, really good for balance. Yoga is good for balance, stretching, posture. We all know with Parkinson's, the posture gets stooped. So any kind of exercise that brings your posture up is really, really helpful. A lot of people really like the pedaling for Parkinson's. That's one of the biggest ones, of course, because that gets your heart rate up. The boxing classes are really fun. I think a lot of people really enjoy those. But I think the most important thing is getting people to do activity as much as possible. And just
for clarification, did you say 3 times a day for 30 minutes or 3 times a week?
Sorry, 3 times a week for 30
Okay, we have
minutes.
some people panicking, so.
I'm sorry, I'm so sorry. I misspoke. 3 times a week for 30 minutes, so an hour and a half a week of high intensity exercise has been shown to slow the progression. But of course, that's at a minimum. You want to do as much as you can.
Exactly.
Yeah, no, super, super helpful. And I think, again, it's just trying to encourage movement. And, you know, as we get older, it's harder, you know, we lose our muscle mass, and it's important to do what we can to keep our muscles active and alive for so many reasons, but definitely to minimize falls. And I think that's so important, because no matter how strong you are with Parkinson's, there's some things that you just can't override, because it's just harder. You know, some muscles become really inaccessible, or they're overworked, like the toes, you know, and just with dystonia. So I think this is really hard. It's really challenging. But wow, what a great hour we've had. We have a couple minutes left. Is there any last thing you'd add, Jessica, in terms of like kind of questions that you've heard here? Or Polly, have we missed something that we really need to get to? Because I wonder with Jessica, like the biggest piece of advice based on sort of what you're hearing of the concerns, something stand out that you can share?
I think the biggest thing is being patient and being kind to yourself and to the person with Parkinson's. This is definitely a journey for sure, and you guys are all in this together. It's not just the person with Parkinson's, it's a whole, it affects the whole family. And being kind to yourself, and being patient, I think, is the biggest thing. There's a lot of variability with Parkinson's, and kind of learning along the way and enjoying the journey, and being kind to yourself, and finding connection with others who are going through the same thing, I think, is so important. And I think it's great that you guys are all here and part of the support group. I think having that connection with other people who are going through the same thing that you guys are going through is so, so, so important. So I'm so glad that you do this, and I hope that it continues to grow, and you guys all can continue to connect.
You're going to be brought back. You know, the last thrown out, and everybody's begging for you to come back. So we got to find another day for that. I think that it is so hard to ask real experts that really care these kind of questions, and to be able, you know, we couldn't answer all of your questions. We'll do our best in the write-up afterwards. We will include every link that we have and try to put some links in there for some of the questions that went unanswered. But, you know, it's challenging. Next month, we have only 1 minute left. So thank you so much, Jessica. But next month, we have another expert, one of our favorites, coming back, Dr. Mark Mapstone, who's a neuropsychologist. And we'll be talking more about cognition and all those questions along those lines. And, you know, he's just a wealth of information. So, you know, share this video when it comes out. We will be sharing that with you. And we'll also be recording the one with Mark next month. Pat and Gail, you continue to show up. I love you both dearly. Thank you. And Polly, for all your work at the foundation, just keep it going. We appreciate everybody for supporting us, and into this new year. We'll be back on February 6th. Okay. Jessica, again, thank you so much.
Thank you.
Thank you.
Thank you for having me, guys.
Take care, everybody. Bye-bye.